Yeah, well, good morning, everyone. Welcome back to another Zoom Nephrology Grand Rounds. It was good to see everyone last week at the faculty retreat, and I think all those sessions went very well. And sorry for those that we missed um, for one reason or another. But anyway, we have a great slate of speakers today. Three of our very own speakers today, and starting off first with Manny Rovira. Talking about water sustainability and dialysis. So we are right at the top of the hour now. So I think we can go ahead and get going.
All right.
Go
Well,
see your
good
slide.
morning. Yep. Good morning. I'll be talking about an important topic, especially with recent news leading to how efficiently use water for dialysis and options in the near future. I'm Manuel Rovira, a second-year nephrology fellow, and we'll talk first about the objective about this presentation. After an introduction, 3 words I would like you to be familiar with. Those are reduce, reuse, recycle. We'll talk about sorbent-based dialysis, mixed matrix membrane, and near-future dialysis modalities. The prevalence of dialysis is currently higher than it was 10, 15 years ago. An average patient in dialysis needs about 500 liters of pre-processed water for each sessions. This sums to 1,500 liters of pre-processed water per week and 78,000 liters of pre-processed water per year per patient. Again, this is before it's processed through the RO system. To put it in perspective, a healthy adult is exposed to 14 liters of water per week. This means an HD patient is exposed to about 100 times more water than the average adult. Not only that, but the RO efficiency in most HD centers is about 30%, and I'm being generous, meaning that about 70% of the water that comes in is rejected. For an average HD unit with 100 patients, this means it needs 7.8 million liters of pre-processed water per year in order to produce ultra pure water of 1.5 million liters per year. And it does rejects about 5.5 million liters of water, and that's RO water per year. That's when in 2008 in Australia, a nephrologist by the name of John Egger incorporated the concept of green dialysis due to home HD patients who experience high water electricity expenses from intense hemodialysis. So several countries started green dialysis policies, including United Kingdom, Canada, and Europe. To have an idea, implementing these policies led United Kingdom to save about 10 million euros annually. This figure summarizes several ways we as nephrologists can integrate water-saving strategies when performing dialysis. These include optimizing dialysate flow rate, monitor water consumption, using concentrate, which we use here, and redesigning the water treatment system. For reducing water, decreasing dialysis flow rate is a quick remedy. Decreasing it to, for example, 400 mLs per minute from 500 mLs per minute show no difference in phosphate removal or small molecule clearance. Only when the dialysate flow fell less than 200 mLs per minute, we started to notice some differences. It does not worsen patient outcomes and helps save 24 liters of dialysate per session, 72 liters of dialysate per week, and 3,700 liters of dialysate per year, and that's per patient. Meaning that changing dialysate rate by 100 mLs per minute provides enough dialysate for at least 30 more hemodialysis sessions per year per patient. That's what we see at the very bottom here. And that's assuming actually a QD of 500 mLs per minute, which requires 120 liters per session. To give an idea, an average HD patient does 156 sessions per year. So if this change is applied to an HD unit, enough dialysate is spare to provide 3,000 additional sessions per year. Or in other words, a yearly dialysate supply to almost 20 patients. And that's only when 100 mLs per minute difference is applied. Another option we're more familiar with is delaying HD start. Based on prior New England Journal of Medicine articles showing no difference between early and late start HD, and recently less likely to have a benefit in quality of life for elderly patients, as presented by Dr. Wong and Dr. O'Hare. For every patient month delay, about 6,000 liters of water are spared. That's because of the 12 HD sessions. Another option is incremental hemodialysis. For example, twice a week will omit 4 sessions per month, which saves 2,000 liters of pre-processed water. The next two concepts have some overlap. However, reusing water, most of the time, it's meant for the same patient and unit. As we said before, most of the processed water from the RO is rejected. However, this is high quality water, even to the point it meets and exceeds EPA regulation. And let me show you some examples of rejected RO water composition. Again, all metrics for EPA are met and exceeded. Currently, there's no legislation for dialysis service to reuse RO rejected water, and no law bans doing it either. Rejected RO water even meets World Health Organization standard for potable water, but it's discarded due to low chlorine levels due to concern for infection when stored for long term. Other uses for rejected RO water can be landscaping, janitor use, toilets, steam generation, laundry, and also recirculating the RO water. As for recirculating the RO water, some new RO systems are considered highly efficient and reject only 30% or less of processed water instead of the usual 70%. An example is Aquabus. These are better conserving water, and the basis again is on recirculating rejected processed water. And for you to have an idea, this one rejects about 22% of the processed water. Another resource to optimize water use is effluent dialysate. This can be used for irrigation or to fertilize when mixed with tap water. It is useful as a fertilizer due to its high phosphate and nitrogen content. Ideally, the main purpose will be for agricultural use. The organic material from the effluent remains way below the World Health Organization and the Food and Agricultural Organization standards. So much to say, effluent dialysate is less polluted than current water used in agricultural practices. Here are some examples of effluent dialysate quality when compared to agricultural standards. Mainly, it has higher conductivity, which can damage growth and roots, resulting in nutrient imbalances. However, these can be quickly solved by mixing it with tap water. High sulfate content increases yield of corn and soybean crops. And as mentioned before, we can see more than 100-fold lower amount of bacteria in effluent dialysate. In regards of recycling water, this is the overlap topic as it can be quite similar to reusing. However, the focus of recycling was leaning more towards redirecting the water use when I was reading about it. It also refers to donating dialysis materials to low-income countries. As a quick summary, some water-saving methods can be reducing dialysate flow rate, reusing RO rejected water, redirecting dialysate effluent, and using newer RO generators, which can reduce waste from 70% to 20%. I'd like you to think about ways we're able to implement such measures in current dialysis centers. Maybe one way is to incentivize dialysis units for optimizing water use. As a way to implement water-saving methods, different hemodialysis modalities and prior techniques are now being explored. Just to let everyone know, dialysate regeneration was highly explored in the 80s, but seems to fail due to technological complexity, limited efficiency, and electrolyte instability at that time. Today, sorbent-based dialysis will be available soon as a water-efficient dialysis. But what is it exactly? Sorbent-based dialysis works by having a column with several layers of different materials to either perform dialysis or to clean dialysate and be able to reuse it. And this is the basis of most wearable artificial kidneys or portable artificial kidneys. This image shows that basis of regenerative dialysis, which we can see that the used dialysate is processed through the sorbent and then reused. Sorbent-based dialysis removes substances that are difficult to remove by conventional dialysis. The activated carbon is quite useful removing uremic toxins. It works by hydrophobic interactions and binds hydrophobic uremic toxins in activated charcoal. It also binds urea, creatinine, and uric acid. A downside can be its biocompatibility. It also has urease, which converts urea into ammonium, which then binds to zirconium layer. It also uses less amount of dialysate. This can be offered as an option in remote and disaster medicine. Here's an example of some of the molecule interactions with the sorbent. We have van der Waals forces or distance-dependent interactions, ionic and hydrophobic bonds. Again, some molecular interactions based on the layers and what it removes. Some of the disadvantage are column saturation and again, biocompatibility. Next, we'll talk briefly about mixed matrix membranes. This will act mainly like current filters for dialysis. However, the composition is a mixture that includes activated carbon with other materials that enhances biocompatibility. And this technique combines diffusion and adsorption. Here is an example of the membrane. In this case, it has particles of ninhydrin, which has highly electrophilic carbonyl groups that bind to nitrogen of urea. This molecule here in the middle is urea, and we can see how it's reacting with ninhydrin. Some of the future dialysis modalities include wearable artificial kidney, which was first tested in 2022 with 14 patients who were in PD and transitioned to wearable artificial kidney. They did more than 10.5 hours per day for 3 days, and their urea, creatinine, and phosphate improved more than 20% without any serious side effects besides some abdominal discomfort. Other new modalities are automated wearable artificial kidney, regenerative.
Yeah, now that we're at the WHO, we can do whatever we want with protected.
So about that, regenerative dialysis, small portable home dialysis, and self-convective hemodialysis, which uses a fixed amount of volume for each cycle and uses a push and pull technique to clean the blood. Here are some of the, here on the left is the small portable home dialysis. It's continuous by generating dialysate, which mostly uses activated carbon and sorbents for phosphate, creatinine, and protein-bound uremic toxin removal. It uses 7 liters. And the drawback is potassium and urea are dependent on the exchanges. This one is similar to PD. The one on the right, we have a wearable artificial kidney. In this case, it's Next Kidney, which uses sorbents and generates dialysate. Usually it's prescribed for 6 times per week. It's a 2-hour per treatment, weighs 22 pounds, and uses 4.5 liters of dialysate. I want to finish by showing you the Kidney X Sustainability 2025 Awards. This prize is a collaboration between ASN and the U.S. Department of Health and Human Services to bring sustainable dialysis. Some of the awardees were dialysis regeneration with 2 liters of water, water-free battery power dialysis that lasts 8 hours. Its main purpose is for dialysis access during disasters. Generating PD fluid from tap water and reusing effluent. A portable near waterless system to optimize dialysis regeneration through sorbents. Decentralized PD fluid generation, and a 2-pound wearable artificial kidney that's powered by rechargeable batteries and can provide continuous dialysis with minimal amount of water. Thank you for your attention.
Thank you, Manny. That was a very interesting presentation. And so with that, we have quite a few minutes for questions if anyone has any. Yes, Manny, I kind of have a question. You presented, thank you for that great introduction to some of these sustainable dialysis modalities that, maybe I'm not so familiar with, and maybe some of others here aren't either. You mentioned that a lot of these uses are for like, disaster medicine or wilderness medicine where resources are more restricted. Do you foresee any uptake kind of in the more mainstream sphere, like such as at a university hospital, such as University of Washington, or how can we kind of participate in trying to do more renewable dialysis?
I think at least from us, I think as I mentioned earlier, I think a quick remedy will be on the dialysis flow rate. I don't think, for example, like a 600, 800 are definitely, I think those can be actually dialed down. and be able to contribute to that water sustainability. In terms of the newer dialysis coming in, I would say probably we'll start in the academic centers as a week trial and then move outside. But I haven't like seen them myself either. But I think that's probably what's going to happen in the future.
Thank you. Any other questions? Suzanne mentioned something in the chat. For those who are interested, there's a Green Dialysis KDIGO conference at the end of April to address this issue. Regarding the 7 Kidney X awards, although they have been awarded, they have not been paid out yet. So we'll see what happens as the administration's transition. Thank you. Matt Rovira has his hand raised. Yeah, go ahead, Matt.
Yeah, thanks so much, and Manny, great presentation. Just a couple other things to think about. There's obviously other parts of sustainable dialysis, including electricity use, including transportation costs of supplies, and then including the plastics themselves. And then there's costs associated with all these things. So one of the reasons that the READY system, the sorbent-based dialysate regeneration system that you mentioned, ultimately failed was cost related because the sorbent canisters were actually very expensive to produce. So, I think that's something that needs to be, taken into account. And then, transportation costs of supplies is a big deal. So, for example, at first glance, peritoneal dialysis would seem to be more sort of quote environmentally friendly than in-center hemodialysis, but I think it really depends on the jurisdiction and area that you're talking about. If there's areas where PD fluid need to be transported across long distances, that actually could provide a sort of environmental hit more potentially than use of large volumes of water. So, so many things to consider here, but thanks for outlining the water-related considerations.
No, it's true in regards of PD, because I was considering that, and a lot we're talking about that too. So it takes up to like 180 liters of water to produce 1 kilo of plastic, and then the 6-liter empty dialysate weighs about 450 grams. So it needs about 81 liters in order to produce the bag, and eventually they showed that just incremental PD was shown to be working more towards water sustainability, because just a full PD seems a bit similar in that sense because of what you just mentioned.
Yeah, Matt, I think that was a good point about PD, and wonderful talk, Manny. Great job. And I noticed that a couple of the KHI awards were related to what you were talking about, Matt, which is more local production or delivery of PD to reduce the total broad costs and environmental impact of dialysis. And that, of course, would also help with supply chain resilience, which was a huge issue just recently. And it's nice to see that there are multiple sort of ways to target this going on in parallel.
Yeah, there's multiple companies, actively working on bedside peritoneal dialysate generation using tap water. And I think in the next few years we'll see clinical trials of those devices. And for those of you at Kidney Week who are walking around, there a number of those companies were actually showing prototype devices there.
Well, very cool. Sounds like lots of wonderful things on the horizon. And Manny, thank you for giving us an early plug to some of this stuff. Really, really great presentation.